So now we have around 18, 19 students. Like once we are halfway through the lecture, so I'm starting recording. Okay, only with the presence of 18, 19 students. Before that, it was around 9, 10 students, so I wasn't recording. So now let's talk about, so far we discussed the pathophysiology of vomiting, different receptors involved, different neurotransmitters involved, and different clinical situations where nausea and vomiting happens, and different clinical entities. Now we'll go into the drugs. So we already discussed the location and the distribution of those receptors which we can target. So antiemetics. So we have different classes based on their targeted receptor. We have classified them based on their mode of action. So which receptor they are targeting. So we have dopamine D2 antagonists. So again, all these drugs you have previously done either in neuro or in POD. So drugs are not new. It's just their new indication. Okay. So we have dopamine D2 antagonists, which include metoclopramide, domperidone, and then again we have some typical antipsychotics as well, which are used as antipsychotics, but they also are very strong antiemetic drugs as well, like prochlorperazine or chlorpromazine. So all of them are D2 antagonists, but like metoclopramide, domperidone are typically used as antiemetic and also sometimes as prokinetic agents as well for the upper GI. For lower GI, prokinetic drugs you will do when you do constipation later in the block. Here, the prokinetic are for the upper GI. And they are also antiemetic drugs as well. And then we have serotonin antagonists, which include ondansetron, granisetron, and palinosetron. Again, it's very easy to remember these names. And probably once I upload, so I'll on this slide, either I'll remove or I'll dim out the names which you don't need to remember. Okay. So probably if you suppose if you don't need to remember granisetron, I'll either make it dim or I'll strike through it. Okay. So that you know probably you don't need to worry about this name, but it's easier to remember all these names. Okay. Then we have antihistamines, and these are mainly the first generation which cross blood-brain barrier, and these are H1 blockers. Dimenhydrinate, diphenhydramine, cyclazine, maclazine, very similar names. Promethazine, very strong antiemetic. And then we have combination. Pyridoxine can also work in morning sickness. Remember we discussed, which is vitamin B6. So for pregnant females, they combine doxylamine with pyridoxine or maclazine with pyridoxine. It's a good combination. So usually they start with some like ginger water, things like that, and then pyridoxine, just alone pyridoxine, vitamin B6, and then if it's not controlled, then they can combine pyridoxine with either maclazine or doxylamine. And if it's not controlled, then they can go on to other drugs. Okay, like there's one thing called hyperemesis gravidarum, which is very severe vomiting during pregnancy, uncontrollable. So again, for that you can go on to other drugs like promethazine and all those things. Then you have antimuscarinics like scopolamine, which is also hyoscine hydrobromide, and this is used for motion sickness. And then corticosteroids like dexamethasone, which is more of an adjuvant, like add-on drug, and then cannabinoids like dronabinol, and then you have benzodiazepines. You have done all of these, huh? And then you have neurokinin 1 receptor antagonist, which blocks the substance P, and one of them is aprepitant. Okay. So let's talk about one by one about all of these in the next 20 minutes. So you have dopamine D2 antagonists, which are metoclopramide, domperidone. What is the difference between the two? Yeah, and the other one doesn't. So which one crosses the blood-brain barrier? Yeah, metoclopramide crosses the blood-brain barrier. Domperidone doesn't. And this is very important. It will help you to understand many things. And both of them are D2 antagonists. So you know dopamine D2 receptors you saw in that figure are distributed in many places. So if you block those, like in chemoreceptor trigger zone, D2 is there. In nucleus tractus solitarius, D2 is there. So if you block those, you can block nausea and vomiting coming from various inputs. So, and metoclopramide is important in that sense. It's commonly used. Domperidone is more of a prokinetic agent, but it helps in nausea and vomiting as well. It antagonizes the D2 receptors in CTZ and solitary tract nucleus, NTS. NTS because the other name is nucleus tractus solitarius. And metoclopramide at higher doses also blocks serotonin receptors. So it has additive advantage. So metoclopramide can be used in even chemotherapy-induced nausea and vomiting as well, because it blocks D2 as well as serotonin. So at a higher dose, so it's very strong antiemetic. And as you know, metoclopramide crosses blood-brain barrier, but domperidone doesn't. So, and that will help you to understand the side effects as well. So one of the side effects would be, if it crosses blood-brain barrier, it will go to the basal ganglia. So it will cause drug-induced Parkinsonism, which would be like extrapyramidal symptoms, unusual body, facial, or tongue movements. So it's drug-induced Parkinsonism, and this will be with. So you know why? Because it also will affect the basal ganglia dopaminergic input. So which drug will cause? Metoclopramide will. Domperidone should not, because it won't go there. Good. Not only with metoclopramide, but not with domperidone. And the reason is because it doesn't cross. Domperidone doesn't cross domperidone. Okay, so we discussed this. The other adverse effect that you see is galactorrhea, gynecomastia, impotence, and menstrual disorders. And why do we have these things? Why? As an adverse effect, why do we get these things? What, like, what is the site of action? You don't remember? Prolactin, So what is the this is what is the inhibition like? What does inhibit prolactin secretion? This is a prolactin inhibitory peptide, which is dopamine. So dopamine inhibits prolactin production. So when you're blocking dopamine, prolactin will be higher. So this is hyperprolactinemia, which lead to all these galactorrhea, gynecomastia, impotence, menstrual disorders. Okay, is that clear? So is it only with metoclopramide or with both metoclopramide and domperidone? Why? Hmm. So is there anything over there which doesn't require, which is there any area in that like infundibulum and where there's deficient blood-brain barrier in infundibular area? You see there's an infundibulum and then the pituitary gland, So is there any area which is deficient in blood-brain barrier? Hmm? I think there is. Traditionally, from that point of view, yes, it should be only, but like both of them cause these things. Like, because see, there's one another use of these drugs besides nausea, preventing nausea and vomiting. Uh, Patients who don't have enough milk output, to stimulate milk output, which is galactorrhea, they are given domperidone and metoclopramide to increase the milk production. So that means both of them are able to do that. So, clinically, both of them are able to do it. Like for that, like even domperidone can be used, metoclopramide can be. Both of them are used. Yeah. So typically, many people say that like it's only the metoclopramide, but my understanding is both of them can do that. It depends on the dosages. Usually, it's like it's not a chronic use, If you're using it chronically, then it does, and obviously, metoclopramide has a more potential of doing that. So, as an adverse effect, obviously, so when you speak of adverse effects, metoclopramide is more implicated, and when it is used chronically, short-term use, uh, it doesn't produce that kind of side effect. Like you need a chronic disinhibition of prolactin production, and that leads to chronic hyperprolactinemia and leading to all these features. So that doesn't happen commonly unless someone has a problem where they are taking it every day for a longer period of time. But both of them has a potential. Metoclopramide has more potential to do that. So again, so if domperidone does not cross blood-brain barrier, then how does it act as an antiemetic since CTZ is in the brain? And we discussed this. Yeah, and that is deficient in blood-brain barrier. Huh? So CTZ is located in the an area postrema, which is outside blood-brain barrier, which is deficient in blood-brain barrier. Okay. So that's why it's able to act like domperidone is able to act as an antiemetic. Okay. And also some if you're giving it an elderly at a higher dose, then it can increase the risk of arrhythmias as well. Clinical uses GI stresses, like as I said, they can work as a prokinetic drugs as well. Huh? So especially those who have like gastroparesis because of diabetes or some other age-related gastroparesis. So they can act as prokinetic. Like pre-meal, you give especially motilium. And migraine, induced nausea, vomiting, chemotherapy, induced nausea, vomiting, metoclopramide is very good for that. And then you have other dopamine antagonists, which are typical antipsychotics, like prochlorperazine and chlorpromazine. They are dopamine antagonists, and they also have anti-serotonergic and antihistaminergic properties as well. So they are very strong antiemetics, and they are used for severe nausea and vomiting associated with cancer, radiation therapy, cytotoxic drugs, opioids, anesthetic drugs, and others. So when we have severe problems, then we go to these drugs, because then they have other adverse effects as well. So you don't want to start with these drugs. They are like probably third line. Then let's come to 5-HT3 antagonists, serotonin antagonists, which we discussed. So you have ondansetron, granisetron, palonosetron. Even if you remember just ondansetron, that should be good enough. And they inhibit nausea, vomiting due to chemotherapy, radiation therapy, anesthesia. Like they can inhibit others, but like this is the common use because they are stronger antiemetics. So we don't use them commonly. The common use, when it comes to chemotherapy, radiotherapy, or anesthesia induced in hospitals, in admitted patients, we give them these drugs, and they block 5-HT3 receptors. And the antiemetic effect continues for longer because the drug interaction with the receptor continues for longer, even if it is gone from the blood circulation. Still, like it's able to produce its effect, so it's a longer duration of action. And palonosetron is superior to others because it has a higher receptor affinity and longer half-life. So probably you can use it once a day. Others probably you might use twice a day or sometimes 3 times a day. And ondansetron, we have oral formulation available as well. Palonosetron, probably we don't have oral formulation, but ondansetron, we have oral formulation as well. Adverse effects, they are well tolerated. Like most common adverse effect is headache. And again, sometimes they can lead to QT prolongation, but again, it's clinically not significant. Clinical use is chemotherapy and radiation therapy induced vomiting, post-operative vomiting. Now let's talk about antihistamines, which again you have done in POD, huh? And most of these are first generation. Dimenhydrinate, diphenhydramine, cyclazine, meclazine, promethazine, and then the combination of doxylamine, pyridoxine, or meclazine, pyridoxine, which is for, so when you're combining pyridoxine, it's more for the motion sickness, morning sickness, for the morning sickness. So, and even sometimes pyridoxine can be given alone, and then it can be combined with these antihistamines. And these are H1 receptor blockers, and they also have some anticholinergic effects as well. So their adverse effects will include anticholinergic effects. Clinical uses motion sickness, morning sickness. All of these can be used for motion sickness and morning sickness. But then promethazine has additional uses because it's a very strong antiemetic. So for morning sickness, like as a second line, when there's a hyperemesis gravidarum, then probably you will, and other drugs are not working, then you go to promethazine. And also chemotherapy induced nausea, vomiting, motion sickness. So promethazine has like slightly stronger effect, so you can use it in other situations. Otherwise, most of these are for the motion sickness and morning sickness. And but as I said, like this combination with vitamin B6 is used for morning sickness. Adverse effects will include anticholinergic side effects like dryness of mouth, blurred vision, and urinary retention, and sedation, because they are first generation. Huh? So would you use second generation for treating motion sickness? Because it won't cross blood-brain barrier, so it won't help. Huh? So you'll stick to those first generation. Antimuscarinics, scopolamine, which is also called hyoscine hydrobromide. Okay, and this blocks muscarinic receptors in the vestibular system and cerebellum, and it has a higher affinity, so it's highly effective in motion sickness. So probably the drug of choice when it comes to motion sickness. Again, it's not recommended for people with angle closure glaucoma and bowel obstruction because it's antimuscarinic, so it is antispasmodic as well. So it will relax the smooth muscles. Huh? So if someone has bowel obstruction, so you don't want to use, so you don't want to relax their bowels, and it will cause further obstruction. Huh? So and also it will increase the, it will affect the drainage, and it will increase the intraocular pressure. So it's not advised in angle closure glaucoma or bowel obstruction. And also antimuscarinics are, as they are antispasmodic and anti-secretory, so you don't give it with prokinetics. Prokinetics like domperidone, they increase the gut motility. Okay. So suppose someone has some nausea, vomiting, you gave them domperidone, and it doesn't work, so you don't add this one because they'll cancel out each other. Huh? Because one is antispasmodic, other is one will decrease the motility, other will increase the motility. So you don't combine these two together. Scopolamine, like not very important, but like, so it's sometimes those who are like always get this problem and they need to travel, or so they use patches instead of taking it like frequently. So they can use transdermal patches, and which is used behind skin, on the skin behind the ear, and this patch can deliver the drug at a constant rate for over 3 days. And so when you apply this patch initially, there's a higher dose which will saturate the skin binding sites, and then there is a constant delivery of scopolamine to maintain a good therapeutic range. And now these are the add-ons like corticosteroids, like dexamethasone. That can also be used for nausea and vomiting in some special situations where other drugs are not working. You've tried other drugs, and then you can add this dexamethasone just to as an adjuvant. Huh? So it helps, but not on a standalone. Huh? So adjuvant to other antiemetics, and especially in chemotherapy-induced nausea, vomiting. So dexamethasone can be helpful. Cannabinoids, like you have, they are derivatives of like cannabinoids. What do you think of which drug? Any drug of abuse that comes to him? Huh? Cannabis, huh? Marijuana. So you have Nebulone and Dronabinol, and so these are active ingredient of these drugs is tetrahydrocannabinol, THC, and it's a psychoactive agent in marijuana, and it's also antiemetic. And we don't know the mode of action, but probably it relates to stimulation of CB1 subtype receptors of cannabinoid receptors, CB1 subtype of cannabinoid receptors on neurons and around the vomiting center. Adverse effects would be increased central sympathomimetic activity, mainly palpitations, euphoria, sedation, and hallucinations, dry mouth, and increased appetite. Clinical uses, again, prevention of, so here, so this prevention of chemotherapy and radiation-induced vomiting. So again, it's more of an adjuvant, add-on. Benzodiazepines. Various like diazepam, lorazepam, alprazolam can be used for this purpose, and they are used prior to the initiation of chemotherapy to reduce anticipatory nausea and vomiting, and also sometimes due to anxiety. So what they do, they just reduce the anxiety. So probably, so remember the anticipatory nausea and vomiting. So the benzodiazepines may be helpful in that situation. Probably the last one, neurokinin 1 or substance P receptor antagonist. You have two drugs, aprepitant, rolapitant. So if you just remember aprepitant, that should be enough. And it's again a non-peptide selective neurokinin type 1 receptor antagonist, blocks substance P from binding to neurokinin 1 receptor, broader spectrum of activity in delayed emesis. So there's two phenomena. One is like there are certain, not all, but certain chemotherapeutic agents which can cause delayed emesis. One is like within, like you gave them chemotherapy, within 24 hours, they'll experience nausea, vomiting. Huh? Then there are other drugs which, a few days later, they can experience nausea, vomiting. So that's delayed emesis. That's another phenomenon. So this has a role in delayed emesis, and it augments the anti-emetic activity of serotonin receptors antagonists and dexamethasone, and it can inhibit chemotherapy-induced nausea and vomiting as well. Okay, and can be given orally or parenterally. Adverse effects: asthenia, hiccups, diarrhea, heartburn, dizziness, elevation in liver enzymes. Okay, so overwhelming. So now this is summary: motion sickness, scopolamine. Huh? Then you can go to the other ones, the histamine blockers as well. Huh? But you'll start with scopolamine, which is muscarinic blocker. Okay, but then you can, if it's not working, then you can go to histamine blockers as well. They can also work, especially when there's a problem with the vestibular, not just motion sickness, but when there's a problem with the vestibular system, then you can go to the histamine receptor blocker as well. Morning sickness, you can start with vitamin B6, and then you can combine it with other drugs like macalazine. Huh? I'll remove the other one, other combination. If you just remember, it's one combination. Chemotherapy-induced nausea, vomiting. Again, you can use metoclopramide like D2 receptor antagonist, then serotonin receptor antagonist, neurokinin 1 receptor antagonist, dexamethasone, cannabinoids as an adjuvant. Anticipatory nausea, vomiting, benzodiazepines. Post-operative vomiting, dopamine antagonist, serotonin receptor antagonist. Gastroenteritis, again, dopamine receptor antagonist, serotonin receptor antagonist. Okay. Is that clear? Now, one slide of prokinetics. So these are agents with medication which enhance the coordinated GI motility and transit of the material in the GI tract. Okay. But we are just talking about the upper GI part, the stomach, especially when there's gastroparesis. Diabetic gastroparesis or old age related gastroparesis. And where you can use metoclopramide, domperidone. Typically, domperidone is more useful because it has less side effects. And cisapride, etopride, which are serotonin 4, HT4 agonist and weak HT3 antagonist. Other prokinetics for the lower GI tract, you'll do it later with the constipation. Okay. This is the last slide. So you have 25-year-old male who's brought in to the emergency complaining of stiff neck. And he's not able to move his neck, and it's like arched towards the right side. The patient said he was not able to move. He has not been able to move it for the past 1.5 hours. And he took some anti-emetic drug before he developed this stiff neck. So what is going on? Like he's developed this, some spasm of some muscle. Huh? Huh? Anticholinergic. Huh? Antihistamine. Hmm? Sorry? Yeah, so it's not Parkinsonism, but it's another same thing, like it's staticolis, huh? It's dystonia. Again, similar thing which happens with extrapyramidal. These are extrapyramidal symptoms, APS, extrapyramidal syndrome, which one of them is Parkinsonism, but the other things are like tardive dyskinesia, ankylosing crisis. Then you have this dystonias where there can be spasm of some muscles. And this particular, when you have this sternocleidomastoid muscle involved in dystonia, you call it torticollis, where neck becomes like this because of the spasm of the sternocleidomastoid. Okay, so he's experienced torticollis, dystonia. Secondary to which drug? Metoclopramide, like so yeah. So any, he might have taken some other antipsychotic. So any dopamine antagonist which crosses blood-brain barrier. Good. So we are done.